Hey everyone, Dr. High Yield here. I'm a surgical resident, and in today's video, we'll be discussing the intern survival guide. As a disclaimer, these responsibilities are at my program, but if they overlap with yours, then that's great. Generally, the intern responsibilities are remember that whatever patients you have been assigned, you own that patient. Take some responsibility. Even though there's seniors on the service helping you out with these patients, you want to treat them as if they were entirely your patient. Everything that comes down to it, it's your patient, and you're using your senior as kind of like a mentor or someone to bounce the ideas off of to formulate a plan for the day. You want to make sure you're getting all your numbers in the morning. On your sheet of paper, write down your fishbone diagram for your CBC and your CMP. Another thing that's important is that you don't want to write down just the current day's values. What I usually do is right next to the fishbone diagram, say like the hemoglobin is 11, then I'll put in brackets 10 next to it, and that tells me that it was the previous day's hemoglobin, so that when I'm presenting, I'm saying, the hemoglobin is stable, it's 11 today, up from 10, because in surgery, trends really matter. So you really want to trend, hemoglobin, white count. We care about sodium a lot, potassium, creatinine. You want to trend these things. At my institution, our interns will order the labs for the next day. So make sure that before you leave, that everyone is all tucked in and they have all their morning labs for the next day. Also, you want to restart your home meds as soon as possible. This is an important thing for the interns, but you want to make sure that you're restarting the ones that need to be restarted and holding the ones that should be held, and you should talk to your senior about that. Usually we hold any blood thinners, anticoagulants, antiplatelets. We hold ACEs, ARBs, because they decrease renal perfusion, and patients who usually go to surgery have a high risk of intraoperative hypotension from anesthesia, and this can increase their risk of postoperative AKI. As a strong intern, you want to make sure that you're circling back on your patient and you've made sure that all the pertinent medications have been restarted. For example, beta blockers have been shown to decrease perioperative mortality. So if a patient's taking a beta blocker, you want to restart that right away. Also, steroids are important too, because certain patients who have autoimmune disorders that are on steroids, you don't want to have them miss that dose and then go into like a Addisonian crisis perioperatively or have refractory hypotension. Post-op checks are very important too. Anytime a patient comes back from surgery, you want to lay your eyes on them, make sure they're awake, oriented, making sure their pain is under control, addressing any of their concerns. At my institution, our interns will often drop a quick clinical note to let the team know that they've seen the patient and that they're stable and doing well. Another intern responsibility is progress notes. Every day, you also want to be able to present your patients. In surgery, presenting patients is an art. We usually try to keep it as concise as possible. This is patient John Doe, 68-year-old male, post-op day 1 lap chole, doing well, pain is under control, incisions look good, passing gas, tolerating clears, will advance diet today. Something very short and brief. And then, just the key is it's an art, but you want to try to be as succinct as possible with your presentations. Interns are also responsible for doing all the discharges. And this is a challenge as an intern because you have to really think about the patient about when they're home. So important things are like, what should they do with their dressings? Should they leave it open to air? If they have staples, when should those staples come out? If they have sutures, when should the sutures come out? Do they have any bathing restrictions? What are their lifting restrictions? A lot of times those restrictions can be anywhere between 4 to 6 weeks, anything greater than 10 to 15 pounds. It really depends on your attending. Or, medications, like what kind of medications should they take? When can they restart their Xarelto or Eliquis again for their AFib? When you're doing these discharges, you really want to think about all those types of things before you discharge them. And if you're unsure, that's the time to ask. Follow up. When do you want them to follow up? Usually if it's, a standard surgery, they'll follow up in 2 weeks. If it's something like a wound that we've debrided or an abscess that we've drained, then we want to follow up sooner, maybe within a week. But again, this is very institutional dependent, so clarify with your team. Pearls for floor success. Again, honesty is a virtue. If you didn't do it or you don't know, just say you don't know. Number 2, load the boat. So if you are unsure of something, call your PGY 2 or PGY 3 resident first. And if they don't know, then they'll call their senior. Again, if the order doesn't exist, then you have to assume that it won't happen. For example, you may be rounding and the nurse may ask, oh, how often do you want me to pack this wound? And you may say, oh, pack it with iodoform packing strips every day. But if the order isn't in there, then as the days go on and new nurses come on and the sign outs change from nurse to nurse, then those instructions that you gave to the nurse won't necessarily happen. So if you really want things to be done, then make sure it's put in as an order. Pearl number 4, take ownership of not only your patients, but take ownership of the service that you are on. That's taking it to the next level, and your seniors will notice and appreciate it, because one of the main things about doing well in residency, it sounds very simple, but you just have to care. Those who care about their patients and care about their service, it really stands out versus those who just want to come to work and go home, and it's just like they just don't care and they just want to go home and it's just another job to them. It's very evident to the seniors and attendings on your service, those who care and those who do not. So if you want to be an excellent resident, then the first thing is taking it to the next level and showing that you care not only about your own patients, but your fellow co-residents' patients as well. And the more you look out for each other, you'll create this culture where everyone kind of looks out for everyone, and it creates a very positive and effective environment for optimal care. Pearl number 5, the nurses know that you don't know. This isn't their first time working with interns, especially the ones who have been around for a while. So sometimes you have to swallow your pride and ask questions intelligently about things. A smart way to ask a question is if you're in a certain situation you don't know about, you can ask a nurse, be like, oh, how are things usually done in this situation? Like, how does Dr. X do it? How does Dr. Y do it? And that way it doesn't make you seem clueless, but it also helps you kind of gauge how things are usually done in the hospital, and that will help you kind of advance throughout your year. Next pearl is notes. At my institution, we're able to copy and paste notes from the previous day forward. If you're going to do that, make sure your note is accurate and making sure it's up to date. Like, a lot of people will rely on and read your notes, and it's embarrassing if they're on the floor and it says the patient is intubated and sedated and they have an arterial line in place. So if you are going to copy forward your notes, make sure to check and make sure that everything is accurate. Pearl number 7, if there's a consultant on your service, make sure that you're reading their notes from that day and their recommendations and have that information ready for you on rounds. Pearl number 8, also read your physical therapy, occupational therapy notes and look at what they're recommending. As the general population in the US gets older, more and more surgical and trauma patients are going to rehab these days. So the quicker you know the disposition, and by disposition that means where they're headed next, you know they're going to a rehab facility. These things are very important as it expedites the patient's next move and their discharge, and it doesn't hold them back at the hospital for more days that they need to be there. The PT OT notes also in there have recommendations of what type of equipment is needed or recommended for the patient to go home. And as an intern, usually you're responsible for the discharges, so having that information really helps you coordinate care with the case manager so that you can have everything ready for them by discharge. On the floor, know who your charge nurse is. The charge nurse is someone who is basically the supervisor or a nurse that is the boss of the other nurses. They're coordinating all the other nurses. Oftentimes, if you have a question that's nursing related or a piece of information or some sort of something you prescribe to the patient that needs to be given stat, for example, a patient with a brain bleed and they need platelets immediately, oftentimes a good move is to talk to the charge nurse and let them know about the plan and the urgency. And then that way, in my experience, when you make those moves, they tend to happen faster and more efficiently. If you come to the floor, I don't recommend doing this often, but if you're in doubt about a diagnosis and you want to get a preliminary workup, these are the shotgun labs. Again, use them sparingly, but if you're completely stumped and you don't know what to do, to order a CBC, a CMP, MAG, FOS, EKG, chest x-ray, ABG. So in surgery, we'll say things like, are they pre-opt? What does that mean? Pre-opt means, are they consented? Are they posted for the OR? Have they been NPO after midnight? Do they have IV fluids running? Have they been type-in screened? Type-in screened meaning that their blood has been typed and screened so that if in the case that they need blood products, that the blood bank is ready to administer those medications. And then also, you want to make sure that they have peri-operative antibiotics on hold. A lot of times, we'll use 2 grams of IV Ancef and making sure that that's available for the patient as needed. So, pre-rounds. So what does that mean? When you're pre-rounding, that means you're basically preparing your patient for the day before rounds. You're getting all their statistics from overnight, all their labs, all their numbers. You're seeing them, you're examining them, you're thinking and formulating a plan before rounding. And everyone has a system. The way I do it is, I'll look at the vitals, their temperature, were they spiking any fevers? It's important if they were persistently febrile. Maybe a one-time fever doesn't get me as excited, but a persistent fever, that's something to note. Were they persistently tachycardic or bradycardic? What were their blood pressure ranges overnight? Then next you want to look at the ins and outs. What was their net? Were they net positive, net negative? Oftentimes I'll even look at the previous day's trends because a lot of times we'll only report the net fluid balance of the previous day, but if you look back, maybe the patient is positive 14 liters over a week, and that really does affect management. You want to look at the output from your JP drains, your chest tubes, your NG tubes, Foley. And then next I'll look at the test results. So any CT scans that came back, any ultrasounds that came back, HIDA scans, MRCPs, I'll note their results. As a surgical resident, you want to start getting into the habit. It's very good form to look at the images yourself. When you're first starting, you may not necessarily be good at reading CT scans, but you'll notice that your attendings and your chief residents, they look at the CT scans themselves all the time. Nothing against radiologists, but remember, they have many CT scans to get through in a day, and they can definitely miss things. So you want to always double check their work and make sure that they're not missing anything. The more you practice looking at these scans, the better you will get. So start early. Then you want to look at the labs. You want to write down all your labs, all the pertinent labs, and their trends. Is the leukocytosis increasing or decreasing? Is the AKI worsening or getting better? Is the sodium you've been watching getting better or worse? Is their hemoglobin stable? These type of things are important to report on rounds. After that's all prepared, then you go see the patient. You want to talk to them. Important questions to ask, especially general surgery, is is your pain controlled? Are you having any nausea, any vomiting? Are you passing gas from below? Have you had any bowel movements yet? Are you having any fevers, any chills? These questions are targeted because a lot of our post-op patients are at risk for ileus, post-operatively, and infections. So when we ask them if they're passing gas, that gives us a gauge, or if they're having nausea or vomiting, that gives us a gauge of whether we can restart their diet or not. When you get all those questions, then you want to look at the incisions and all the drains and tubes. So you want to look at the incision, is it clean, is it dry, is it intact, is there any purulent discharge, is there any erythema? You want to look at their colostomies. Is the colostomy pink, which is a good sign of perfusion? Is it patent? Is there any output? And then you want to look at the bag or the drains and the tubes. Is the bag, does it have thin, clear brown output, or is it like a thick, fully formed stool? You want to look at the chest tube. Is there an air leak or not? Is it to water suction or is it to water seal? Is to check for the air leak, you look for bubbles. If there's any bubbles coming out of the pleurovac, then there's a positive air leak. What color is the output? Is it serous or is it serosanguinous? You want to look at the JP drains. Are the JP drains serous or serosanguinous, or is it pure blood, or is it bilious? These are qualities that your attendings and seniors will always ask you. So if you are prepared with that information, it'll be a smoother day and a more stronger presentation. NG tube, is the NG tube bilious? Is it yellow? Is there blood? These are very important questions. So you want to note the amount. So ABC, right? Amount. Is there blood? What color is it? After you've seen the patient, then you'll go on to rounds. And then on rounds, there's going to be a lot of check boxes that you're going to have to make to execute things. And then the rest of your day, you'll be trying to execute these tasks before sign out. And then if you do have some downtime, if you've pre-rounded quick enough, then again, in surgery residency, efficiency is king. So anytime you have downtime, think about, is there something I could be doing right now to save time so that I don't have to do it later? If there's downtime, I'll put in the labs that I already know I need to order, or a medication that needs to be restarted. I'll start drafting up progress notes ahead of time, save it as a draft, and then addend it or revise it after rounds. Any sort of downtime, think about, is there any task I could be executing right now? Your order of priority as an intern is number 1, orders first. Number 2, talk to your consultants next. Number 3, discharges. Discharges, the earlier in the day, the better. Number 4, update your signouts for your night team or for whoever will be taking over the service when you're leaving. And then finally, your progress notes, which happen last.